And there will be no class next week with school vacation, but we will resume the week after on January 3rd. Tonight we are going to be covering Chapter 15, which is Basics of Procedural Coding. So next week during vacation, what you should be doing is just making sure that you are caught up through Chapter 15 and including Chapter 15. And then we will finish up the remaining 8 chapters when we come back after the first of the year. So the procedural coding, we're going to talk about the organization of the current procedural terminology manual, a little bit of history, alphabetic and tabular index like we talked about last week in the diagnostic coding, the 6 different sections. We'll talk about special reports and how that applies to codes, conventions, documentation. So if you look in your textbook, this starts on page 281. And again, the procedural coding is assigning a code for each specific medical procedure or what was done for the patient, such as an office visit, an injection, a lab test, an x-ray, some sort of surgery, anything like that. The medical biller is responsible for maintaining accurate medical record keeping and for processing insurance claims efficiently by using CPT and HCPCS codes, which identify the services that we are providing, as well as the appropriate diagnostic codes that we talked about last week. So the CPT manual, or current procedural terminology, is developed and maintained by the American Medical Association. It is updated yearly. It is released on October 1st, but it starts on January 1st. So last week we talked about the diagnostic coding. That starts on October 1st. So we are already using, since October 1st, we've been using the ICD-10 book for 2018. The procedure book we start using in January. Again, you can purchase it in October, but it does not start till January 1. So it is updated yearly. So again, you'll hear me stress the importance of making sure you use updated manuals. So the CPT manual is organized by Category 1, Category 2, and Category 3 codes. So as you can see on page 281, the Category 1 codes are arranged by sections. They begin, codes beginning with 7, for example, are X-ray codes. And Category 1 codes are listed in the tabular list of the CPT manual, arranged by section. Your Category 2 codes are supplemental tracking codes that providers use for performance measures. So, for example, Medicare with quality reporting and PQRS and MIPS. They use Category 2 codes, which you have to report in order to get, not bonuses, but an extra percentage. If you do not use Category 2 codes and you ought not to do those performance measure reporting, then you actually get dinged a percentage. And if you continue not to use them, it increases each year up to a point and then maxes out. So you could actually lose money for your provider if they chose not to use these quality performance measures. Category 2 codes are described and listed in Appendix H of the CPT manual. They are alphabetic by condition. Category 3 codes are temporary codes assigned for new upcoming technology. They've not officially been added to the tabular list of the CPT manual. They are intended to be used for data collection purposes. On page 282, the Category 3 codes may be used in billing and reporting if there is no Category 1 code that accurately describes what your provider is performing. What happens with the Category 3 codes is if we use them, again, it means there was no Category 1 code to describe what our provider did, but there are also no RVUs assigned to Category 3 codes. So if you submit a Category 3 code, you need to submit your documentation. You need to assign an amount that your provider feels is appropriate for that procedure that he performed, and then the insurance company will review the notes and determine what, if anything, they will pay you for. Category 3 codes are usually non-reimbursable. That's why we try to get them to a Category 1 status. So the more your provider uses those Category 3 codes, the more they can push to have it activated or added as a Category 1 code. The CPT manual uses a 5-digit classification system. So again, it communicates accurately on procedures and services that the providers are performing to the insurance companies. The AMA first published the CPT in 1966. When it was first published, it was only surgery codes. They only had 4 digits. Then it continued to be published from there and obviously has advanced greatly. The format of the CPT, we have instructions for using the manual. We have an alphabetical index. We have a tabular list, which I call my numeric list. We have coding guidelines, conventions, and note, and then we have appendixes. So your alphabetical index is just that, alphabetic, organized by main terms, type of surgery, anatomic site, or eponym. So we use it the same as we do our diagnostic. We look everything up alphabetically. It will give us 1, 2, a range of codes. We take those numbers and then go to our tabular or numeric, read the description, read notes, and then determine what code we can select. Your tabular, again, which is your numeric list, is divided into 6 sections: evaluation and management, anesthesia, surgery, radiology, which is nuclear medicine and diagnostic ultrasound, path and lab, and medicine. And the medicine section does not include anesthesiology. We have our own anesthesia section for that. And you can see in your textbook on page 282, it breaks down the range of codes for each of those sections. Sections are subdivided into subsections, and subsections are subdivided into categories, and categories can be subdivided into subcategories. Each section and subsection provides coding guidelines and, if needed, a reference to a CPT assistant, which is a little book that can be purchased that gives you coding examples and publishing information about when things were published, about when that code changed or anything like that. Excuse me. In the CPT manual, subsection is listed below the section and indented 2 spaces. Usually describes an anatomic site or an organ system. So the anatomic site would be, for example, heart, femur, skull. Organ system would be integumentary, cardiology, digestive, reproductive, for example. And then listed below the subsection and also indented 2 spaces can be like the name of the procedure. What did we do? Hysterectomy, esophagectomy, bronchoscopy. Specific anatomic site, mitral valve, distal femur, occipital bone, just to give you a couple. Subcategory is the lowest level of code description. The first section on page 283, again, is your evaluation and management section. These codes range from 99201 to 99499. And in the E&M section, these are office visits, hospital visits, consultation, skilled nursing, rest home, nursing home visits. And within those codes, it will be specified whether we are seeing a new patient or an established patient. And we'll go over the difference between a new and established patient upcoming here. So there's different types of services depending on what type of patient they are, what we are doing, and where the patient is being seen. The next section is the anesthesia section. These includes codes for anesthesia services rendered by anesthesiologists and anesthetists before, during, and after surgery. These codes start with 00100 and go to 01999. And then there is a few codes, 99100 to 99140. And if you were to look those up, they're anesthesia codes per se, but they're conscious sedation codes. So it's a form of anesthesia. Codes included for types of anesthesia given, other support services, and monitoring services. The next section is the surgery section. This is the largest section in the CPT. It's codes for all invasive surgical procedures done by providers or qualified profession. An invasive procedure is where a body orifice or the skin needs to be penetrated by cutting or puncture. This section is divided into subsections that typically identify specific body systems. So within the surgery section, for example, we have the integumentary, which is the skin. We have the musculoskeletal. We have the digestive, cardiology, reproductive. So again, the surgery section is the largest section in the CPT manual. Radiology section. The radiology section includes codes for diagnostic imaging, X-ray studies, body scans, therapy used in treatment of cancer. These codes range from 70000 to 7999. They include all diagnostic tests performed on bodily fluids and tissues, including urine, blood, sputum, feces, excised or biopsied cells, tissues, or body organs. And those codes range for the biopsy pathology 80076 to 80100 to 8999. That is the 80076 and the 80100 are the pathology and laboratory section. And again, bodily fluids, tissues that have been excised, anything that's been biopsied. So typically it's the facility billing for this as they prep the tissues to be interpreted by the pathologist, for example. If you look on 283, those 15.2 and 15.3, those are just giving you, the top one is some sample anesthesia codes and descriptions, and the second one are some sample surgical codes. If you look on 284, again on the left-hand side, some radiology codes and descriptions. So 72020, radiological examination spine single view, and it tells us we have to specify the level. So that means on our claim form, we would have to specify what level of the spine they are viewing. You can see 72050 is a radiological exam of the spine, cervical, and then it's 4 or 5 views. So that cervical is actually broken down by the number of views. So it's important to know the number of views, because if we don't, we're billing the lower code, which is only 1 or 2 or 2 or 3 views. And if we did more, we are losing that income for our provider. The figure on the bottom is an example of a lab test or organ panel, for example. The next section is the medicine section. Codes range 90281 to 99199 and 99500 to 99607. These are varied subsections, categories, and subcategories. Non-invasive diagnostic test. There's some ophthalmology, otolaryngology, allergy testing in here. These are grouped in the medicine section rather than in the evaluation and management. Cochlear implants, EKGs, again, allergy testing. Up on the top of 285, we are going to talk just a little bit about unlisted procedure or service code. So periodically, you are going to, even with your documentation, not be able to find a CPT code that supports what your doctor has done. In each section of your CPT manual, there are what we call unlisted procedure codes and services. So for example, in the surgery section, 29999 is a musculoskeletal, and it's unlisted procedure arthroscopy. So with using these unlisted procedure codes, again, we want to send the documentation that the provider has performed. Reason for that is because if we are billing an unlisted procedure code, the insurance companies have no way of knowing exactly what was done, so they would reimburse you absolutely as little as possible. By showing the documentation, if indeed the unlisted code was the only one that was appropriate, they will read the report and they will reimburse appropriately. This also allows, for reporting purposes, them to see what type of procedures are being done where unlisted procedure codes need to be used. And possibly, if we have numerous physicians doing the same procedure and they're having to bill an unlisted procedure because there is not a CPT code for it, then their medical organizations can push for a CPT code to be developed, so we no longer would have to use an unlisted procedure code. But again, the only way they are going to know that is the documentation. If you send the documentation and there should actually be, or there is, a CPT code that you should have used, the insurance company will deny the claim, telling you the documentation does not support the CPT code used. And usually that means that there is a code out there that describes what your provider is doing. CPT coding guidelines. These are at the beginning of each section and some subsections of your CPT. They help the coder's understanding of when and under what circumstances certain codes may be used. Talks about modifiers, which are 2-digit alphanumeric codes that report or indicate criteria or certain circumstances that may or may not affect your reimbursement. Modifiers are included with the 5-digit CPT code, and again, your modifiers supply additional information. So it's important to read the guidelines every time your codes are updated, so on a yearly basis, because they can change. And if you select a code without reading the guideline, it's possible you could be selecting the wrong code. The CPT conventions, these are special symbols, and they're used to provide additional information about specific codes. The CPT conventions, depending on the publisher, are right in your CPT book. Usually they're on the bottom of every page. So it will give you, for example, a plus symbol. And that plus symbol tells us that that is an add-on code. so it can never be billed by itself. Some other symbols you can see on page 285, a triangle, black triangle. That means a revised code. So that means the code has changed. Just a black dot, a new code. Inverted triangles, new or revised text, meaning the wording has changed, which means if that was a code you used previously, depending on what wording has changed, it may or may not still be the code you want to use. And again, the plus symbol, lightning bolt, FDA, pending FDA approval, just to name a few of them. And again, pending the publisher, the symbols may be color-coded or a little bit different, but still mean the same thing. The appendices. Whoops, wrong one. There are 14 appendices to organize changes to the original code set. If you look on page 286, Appendix A has the list of modifiers that are current and gives a very thorough description. Appendix B has a summary of additions, deletions, and revisions. So we're able to go there and see if a code has been added or deleted. C, clinical examples, so narrative descriptions. Appendix D, add-on codes, so it gives a whole list of every code in your CPT book that has the plus symbol next to it. E, modifier 51 exempt code. F, CPT codes that are exempt from modifier 63. G, CPT codes that include moderate sedation. So if you were not sure whether you could bill moderate sedation separate, you could go to this list, and if the code is on there, it already includes sedation. You cannot bill it separate. Appendix H, alphabetical listing of performance measures. Appendix I, genetic testing modifiers. Appendix J, electrodiagnostic medicine listing of sensory, motor, and mixed nerves. Appendix K is pending FDA approval. Appendix L is our vascular family, which is your circulatory system, which we like to think of it as like tree branches. Your vascular family just branches off from a tree, so to speak. Appendix M, renumbered CPT codes. So it's a crosswalk. So if, let's say, last year you may have used in 2017 29870, and that code has now been deleted. That code, if it's in Appendix M, will crosswalk and give you the current code that you should be using instead. Appendix N, resequenced CPT codes. So in our CPT book, most of it is all in numerical order, but there's a few that are out of sequence. O is multi-analytic assays and algorithmic analysis. So some of these appendixes may be ones that you use frequently, and others you may not ever use at all. Medical documentation for CPT coding. So medical records used for procedural coding can include your encounter form, your history and physical, progress notes, discharge summary, operative report, path report, anesthesia, and radiology. So when you compare medical documentation to the code, all of the elements need to match that code description. So if you look on the bottom of 286, if you were to look in a CPT book and look at 21325 and 21320, both codes describe the closed treatment of a nasal bone fracture. However, the 25 indicates there is no stabilization, and 20 indicates there is stabilization. So we would need to know whether or not stabilization occurred. If we did not know, then we have to assume there was no stabilization, But again, that could affect our reimbursement if indeed stabilization was performed. So our CPT code we want to select needs to most closely match the description of what was done. If you look on page 287, this is just an example of an encounter form, and sometimes it's done electronic these days, but it gives the patient information, the date of service, and for this particular office, up at the top of the form, are CPT codes that are performed in their office. So the provider would circle or put a little check mark next to those that are done. Then on the bottom, there are ICD-10 codes, which are our diagnostic codes that we talked about last week. So therefore, they would check off what they are seeing the patient for. And then we use this as a starting point to enter the charges into the computer to submit to the insurance carrier. Some providers have CPT codes, and again, the ICD-10 codes printed on their encounter form. But again, if you are putting them on your encounter form like that, they need to be updated annually when your CPT and your diagnostic codes change as well. Otherwise, you may be using, again, outdated codes. On 288, steps for efficient CPT procedural coding. It includes the use of the alphabetical index and the tabular and applies to all sections of the CPT manual except E&M and anesthesia. So to start the procedural coding system, we need to determine everything that was done for the patient. What did they have done? An office visit, throat culture, x-ray, whatever it happens to be. Abstract the statement documented in the health record, compare it with the encounter form or an OC note or other documentation to make sure we have all procedures that have been recorded. The abstract term used as a verb is the process of collecting pertinent medical information needed to assign the correct code. This ensures all medical procedures and services are identified and none are omitted. And again, we try to do that by using main terms, anatomic body parts. So we try to make sure that the provider is capturing everything that they've done, because sometimes they move quickly and they may have forgotten to check off an x-ray on that form. And if we forget to bill that x-ray, let's say it was a $75 x-ray, even 5 of those every week can be a loss of income of $400 or more times 52 weeks. So we are trying very hard to pull that information to make sure the providers are giving us everything that needs to be billed. If you look, for example, on 289, this is just an operative report, and it gives you the name of the patient, the date of the procedure, pre- and post-operative diagnosis, which in this case is the same, which is great. And then the name of the procedure. This patient had a laparoscopic cholecystectomy and intraoperative cystic duct choleangiogram. So when we are coding this, we're going to be looking for that laparoscopic cholecystectomy and then the choleangiogram. And our diagnosis is acute cholecystitis. So this one's a pretty straightforward. Sometimes we have to go through and read the body of the report, maybe to get specific sizes or something that the provider may not have given us. But typically, it is given to you in this type of format. On 290, using the alphabetical index. So again, we look everything up alphabetically. It will lead us to 1, 2, a range of codes, whatever it happens to be. And then what you're going to do is take those codes that it gives you, go to your tabular list, look it up, and see if it meets the description. It is not a substitute for the tabular list. I tell all my coding students, you always look it up alphabetically. Always check the tabular. The index is similar to that found in any textbook. It's got main and modifying terms. Term and index is followed by reference code or code range. And it is, again, organized by main terms that can stand alone. It has modifying terms that are indented 2 spaces below the main term. Further describe or add information to a definition needed to further or narrow down our search. After selection of the appropriate codes, we can then look at modifying terms as well. So review the list of modifying terms. It gives us additional information, added verbiage, for example. So when we search our alphabetical index, you can do it a couple of different ways. You can begin your search by using one or all 4 primary classifications. So you can start by looking at what was done. Was it an exam, an excision, an arthroscopy, a repair? We can look by organ or anatomic site, clavicle, liver, humerus. The condition, illness, or injury. Was it a fracture, a pregnancy, abdominal pain? Eponym, synonym, abbreviation, or acronym. MRI for magnetic resonance imaging. TURP for transurethral resection of the prostate. Or again, if we knew the proper name for a procedure that may have been named after somebody, we can look it up that way. Sometimes searching for a main term may not yield any results. So when a main term cannot be found, try another word in that list. So, for example, removal of skin tags on neck. I teach my coding students, I say, what word would you start with? Some would say removal, some would say skin tags, and others might say neck. We may find it under all 3 different ways, or we may not. So if you went to neck and you didn't find removal or you didn't find skin tags, then you need to go back and read your description and try one of the other words instead. So again, in this case, the procedure is a removal. The organ is the neck skin. The condition is a skin tag. There's no eponym. So again, it could be all 3 of them will lead us in the correct direction, or only one may lead us in that direction. We have some descriptions that will say see or see also. The C statement in your alphabetical index points to another location to find a code or code range. And the C also points to additional codes in the alphabetical index that may be useful to the code found in the original search. We have the use of a semicolon. Semicolon at the end of a main description indicates that modifying terms and descriptions follow. Every indented description below a standalone code is related to that standalone code. So what that means is if you look back, for example, on page 284. So if you looked at that 72040 code, I said radiological examination, spine, cervical, and then you see that semicolon. That's the base description. That's the standalone code. Then if you look at 72050, all it says is 4 or 5 views. So we have to go back and read up to that semicolon and then stick that information in. So 72050 would be radiological examination, spine, cervical, 4 or 5 views. Okay? Just to give you a little idea. It does show 61314 at the top of page 298 with a semicolon as well, but it's used differently with a standalone codes. So in your alphabetical index, again, a procedure may be listed with a single code or a range of possible codes. Sometimes it can be quite complex. There may be a single code, which is called, again, a standalone code, or a code range that may include one term but has several modifying factors. In some cases, a standalone code and a range of codes are listed. Once a standalone code or a range of codes have been found in the alphabetical index, the next step is to go look up each one of those. And we need to read them to see which one is going to fit. And again, that was an example I just used of the radiology for the standalone and indented. Using the tabular list. So once we've got the code or codes from your alphabetical list, we are then going to take that into our tabular or numeric, find the numbers. We are going to look up each code, and we are going to read the description of each code thoroughly to ensure the main terms that we pulled out of the statement or the chart match the medical documentation. It's pretty straightforward. Sometimes one word or how, maybe it wasn't done by cryo, it was done by heat, and that can make the difference of the code that we select. So reading carefully is key when we take our numbers in that list and verify. On page 292, section specific CPT coding guidelines. To properly code E&M services, we have to have a different technique than looking it up alphabetically, because our E&M codes are, again, our office visit codes. They're the very first part of your CPT manual. So typically, what I do is I go to my E&M section. I find what type of visit I'm looking for, whether it's an office visit, a hospital visit, an ER visit, a consultation, and then I go to that section of codes, and then I start reading to see what matches what my provider may have performed. The E&M section is divided, again, office, emergency, hospital, consultations, place of service. So was it in the office? Was it in the ER? Was it in a skilled nursing? And then again, I mentioned earlier whether or not the patient is new or established. So your first two steps in selecting an E&M code is to find out where it took place. So the place of service. Then we need to determine the patient status. So are they new or established? So again, your place of service, office, hospital, ER, nursing home, whatever it happens to be. On the bottom of 294, your patient status, new or established. A new patient is someone who has not received professional services from the provider or any provider in the exact same specialty or subspecialty in the same group practice within the past 3 years. Established patient is somebody who has been seen within the last 3 years. So let's say you have 4 providers in your office, and Dr. A has seen the patient, but Dr. B has never seen the patient, and Dr. A is away on vacation. Dr. B cannot bill that patient as a new patient because he's never seen him before. If they are billing under the same tax ID number, that patient is established to the practice. So new versus established. On page 294, this is just some common codes for place of service. And this would be already programmed into your practice management system But if you were billing services for a pharmacy, your place of service code would be 01. An office is 11, 12 is a home, outpatient hospital 22, hospice 34. So again, depending what kind of services your provider performs, the most frequent one you're probably going to use is office, but if they do procedures at the hospital, you could also be using outpatient hospital or inpatient hospital. Once we establish the place of service and whether they're new or established, we need to determine the level of service provided. Again, this is mostly done by your provider, but we need to understand how they are coming up with it. The three key components for E&M coding are history, exam, and medical decision making. Along with those three, there are 4 contributing factors: counseling, nature of the presenting problem, coordination of care, and time. So the history, exam, and medical decision making are considered primary because they're the most important. And then the other one, the counseling and the coordination of care and time, they are considered secondary considerations. So if you look up at figure 1510, for example, to select the appropriate level of E&M, we have to look at the history, exam, and decision making, where they were seen, new or established, and then in our CPT manual, we have to read the descriptions, for example, for a new patient visit. Because a new patient visit says that they have to meet all 3 key components. Your key components are your history, exam, and decision making. So if that particular code says detailed history, detailed exam, and moderate decision making, your provider would need to have all 3 of those in order to bill that level code. So the history. There are 4 levels of history. Problem focus. This concentrates on the chief complaint, the symptoms, severity, duration of the problem. Usually does not include a review of systems or family or social history. Expanded problem focus, history. The provider proceeds as in problem focus, but they include a review of systems relative to the chief complaint. Usually the past, family, and social are not included. Detailed history, chief complaint, extended history of present illness, problem pertinent review of systems, pertinent past, family, and social. Comprehensive includes chief complaint, extended history of present illness, review of systems directly related to problem, plus a review of additional body systems, and a complete past, family, and social history. We're not the ones deciding what level history the provider is doing. The provider is doing that. But it's nice for us to understand what those components are. With regards to the examination, this is the objective part of the patient's visit, the measurable findings, and when they do an examination, they will refer to body areas, which is head, including neck and including face and neck, chest, including breast and axilla, abdomen, genitalia, groin, and buttocks, and back, which includes the spine and extremities. And then we have our organs and organ systems. So we have constitutional symptoms, which are your vital signs, general appearance. Eyes, ear, nose, throat, and mouth. Cardiovascular, respiratory, GI, GU, musculoskeletal, just to name a few. So when your docs are doing these exams or body organ review of systems, it has to be pertinent to the problem that the patient is being seen for. It has to be medically necessary. So somebody coming in with an ear infection, for example, chances are, unless the patient has some sort of cardiovascular history, there's really no need to do a review of systems or an exam on the cardiovascular system. Levels of exam, again, problem focused. This is limited to the single body area or body system in the chief complaint. So again, if it's an ear infection, it would be limited to the ear. Expanded problem focused, in addition to limited body area or system, related body area or organ systems. So again, that ear infection, now maybe they're going to include the throat and or chest because the patient's raspy, maybe having some congestion, raising stuff with the ear draining, possibly. Detailed exam, extended exam on the related body areas or organ systems, and the comprehensive is a multi-system exam or a complete exam of a single organ system. After they do the exam, then there's the medical decision making. So what do they need to do to educate the patient? What do they need to do for the patient? What do they need to order? They will take into effect the number of diagnoses and or management options, the amount and or complexity of data to be obtained, reviewed, or analyzed, and the risk of complications and or morbidity or mortality. So again, they're going to look at how many things they're managing. Are they minor? Are they stable? Are they worsening? If there's data to be reviewed. So has the patient had lab work, x-ray, If they're new to you, what type of information did you obtain from their primary care to review their records? Risk of complications. So what happens if it goes untreated or they don't have care or test? Mortality, anything like that. Complexity levels in medical decision making are categorized in 4. So we have straightforward, low, moderate, and high. So again, if you look down at the bottom of this page, you will see in order for it to be a straightforward decision making, it needs to have minimal diagnoses, minimal or no data to be reviewed, and minimal risk of complication. For it to be low complexity, limited number of diagnoses, limited data to be reviewed, and low risk of complications. So again, your providers have these tools to help them determine what level of decision making. Some factors that can help contribute to the complexity is counseling. So counseling a patient and or their family about test results, recommended studies, prognosis, treatment options, follow-up, anything like that. If this factor supersedes, so to speak, 50% of the time spent with the patient, then we can include time in helping the provider select the E&M code. The problem with time is your physician needs to document time, and that's start time to finish time. And a lot of times they're not going to look at a watch to see how long they're in a room or how long with that patient. Nature of the presenting problem, this is typically in the chief complaint. So again, something as simple as a cold or something more detailed as chest pain or complicated. Coordination of care, sometimes they have to coordinate with an outside facility. They're transferring the patient for a transplant. They have to coordinate with hospice, for example. Anything like that. Coordination of care. This can be considered only, again, if it exceeds 50% of the patient encounter. And time is included in the code descriptions just to assist the providers in selecting the most appropriate code. So for example, in your CPT manual, there's a code 99213, which is a mid-level follow-up office visit. And it says suggested time, 15 minutes. That just gives the provider an idea that if he bills that 99213 code, it probably was about a 15-minute visit, and then again, the documentation needs to support the appropriate elements of the history, exam, and medical decision making. And again, code time, when counseling exceeds more than 50% of the encounter, time can be used to help select the appropriate code if time is documented. When you first look at E&M coding, it can be difficult, but the more you do it, the easier it gets, the more you become familiar with codes. And again, some offices just bill strictly office visit codes. So the more you use those office visit codes, there's only a handful of them. They become very familiar. Common CPT coding guidelines for anesthesia. Anesthesiologists and certified registered nurse anesthetists, CRNAs, they bill codes in the anesthesia section, which is the second section in your CPT manual. These codes always start with a 0 and identify anatomic location of the surgery performed. Anesthesia coding differs from any other form of coding in the way that it is billed. They're paid a standard amount per unit compared to surgeons who are paid by the procedure. So anesthesiologists are paid on a formula which is base unit values plus time plus modifying factors. That is all then multiplied by a dollar amount, which the insurance companies call a conversion factor, and that's what the anesthesiologists are paid. So again, base unit, time unit, modifying units. So again, you can see below on 296, the base unit value assigns a numeric value to each service based on complexity. Time, this is the time during which the anesthesia was administered, an hour and minutes, and typically 15 minutes equals 1 unit. But again, if you are billing anesthesia, you want to find out your insurance carriers, because there are some insurance carriers that may do it strictly by minutes. So 1 minute is 1 unit, and some do 15 minutes as 1 unit. So you want to make sure, because that can make a big difference in your reimbursement if it's billed incorrectly. And then the modifying units are circumstances or conditions that change or modify the environment in which the anesthesia was provided. So your qualifying circumstances, for example, if you look down below on table 15.6, there are 4 qualifying circumstances, and this lists only 3 of them, but just to give you an idea, it would be patients of extreme age, controlled hypotension, and then hypothermia. So again, if anesthesia is given on a patient of extreme age, we're going to use this qualifying circumstance code in addition to our anesthesia code, and it's possibly going to give your provider more money. Because that patient was of an extreme age, it made it harder to monitor or made it more difficult for that patient to have anesthesia or that surgery. Also in this table are physical status modifiers, and you can see there are 6 of them, P1 through P6. P1 meaning a normal healthy patient, P2, patient with mild systemic disease, severe systemic disease, constant threat to life, moribund patient not expected to survive without procedure, and then a declared brain dead. Each of these 6 physical status modifiers have a numeric value assigned to it. which adds to that modifying units to possibly get you more reimbursement. So obviously on the P6, that value is 0, because if they're brain dead, it does not make that procedure anesthesia-wise any more complicated. Normal healthy patient, again, that's pretty straightforward. But somebody that has mild systemic disease might make that anesthesiologist have to monitor a little bit more carefully. So that might add another 1 or 2 units, which if the conversion factor is, let's say, $50 and it's an extra 2 units, that just gave your provider an extra $100, just to give you an idea. If you look on 297, this is a copy of an anesthesia record. So it allows the anesthesiologist to put the procedure that was done, the start and stop time, monitors, equipment, checking the airway, blood pressures, fluids, anything like that that they need to then submit for billing purposes. So again, they're going to take that base time and modifying units, and a conversion factor is the dollar value, and each third-party payer has a list of conversion factors, and most of the time it's based on geographic location. So an anesthesiologist in Boston, their conversion factor could be different than an anesthesiologist in Portland, Maine. But they will take those number of units, so let's say it added up to 6. They'll take 6 times the dollar amount, which let's say was 50, and they would get paid $300 for that anesthesia service. Calculating it, again, B for basic unit value, M modifying unit, and T for time. And then again, we would add our physical status modifiers or our qualifying circumstances. And again, if you look on page 298, you will see an example of that conversion factor. Like in New York, Manhattan, it's $22.65. But in North Dakota, for that same anesthesia procedure, it's only $19.70. And then again, the bottom box, 1513, gives an example of a patient in good condition having a laparoscopy, gives the time. It's a total of 12 units. So if in that North Carolina it states those 12 units were $15.77, it would work out to $189.24 that provider would get reimbursed. After anesthesia, it goes into, again, we talked about the surgery section. So there are specific guidelines related to surgery coding. So again, making sure we read those guidelines. A surgical package definition includes patient prep, surgical care, and post-surgical care in a single code. These are considered global services because it's already built into the surgical cost. So for example, somebody having a hysterectomy, let's say that CPT code has a value of $5,000. That $5,000 includes the pre-op visit, the surgery itself, and then the post-op time period where you take care of that patient during that global period. It includes, if you look on 298 in the second column, local infiltration, digital block, or topical anesthesia. Subsequent to the decision for surgery, 1 office visit on the day of or day before procedure. Immediate post-operative care. Writing orders for post-surgical care. Evaluating patient in post-anesthesia recovery area. And typical post-operative follow-up care, which may be 6 to 8 weeks, depending on the patient's surgery. NCCI edits and unbundled codes in order to prevent fraudulent coding. CMS, Centers for Medicare and Medicaid, established National Correct Coding Initiative, or NCCI edit list. This has 2 columns of codes, and the codes in the 2 columns are mutually exclusive. So that means submitted claims that contain mutually exclusive codes are rejected. So when a CPT procedure is billed, this code includes services related to prepping the patient for the procedure, performing the procedure, and suturing to complete the procedure. The single code for this procedure is called a bundled code because it represents all the stages. So what happens is if we try to unbundle it and bill each stage separate, we're committing fraud because there is one code that includes all those things. So again, this correct coding initiative, if you are coding surgeries for your provider, you can go right out there onto CMS's website. You can print it off, pertinent to the codes that you bill, and you can see whether or not you can bill certain codes together. And that helps you learn. My doctor does knee scopes. And when he does a knee scope, he'll do a meniscal repair, and he also removes loose bodies in the knees. Well, that's 2 different procedures, but according to Medicare, I can't bill the removal of those loose bodies separate. So even though the doctor's doing an extra procedure, I can't bill for it. If I tried to bill for it, then to them it looks like I'm trying to get more money than we are or should be getting paid. And they would be looking to see if I am fraudulently billing. The integumentary system, excision of lesions, benign or malignant. Benign lesion excision includes a simple closure and anesthesia. So when we talk about levels of closure or repair, we have simple, which is when the wound is superficial, no involvement or significant involvement of deeper structures, and it includes local anesthesia or chemical or electrocautery of wounds. Intermediate repair includes simple repair with a need for, layered closure of deeper layers of subcutaneous tissue. Single layer closure of heavily contaminated wounds require extensive cleaning or removal of matter, also constitute intermediate repair. And then a complex repair is more than layered closure, and can possibly, complex repair does not include excision of benign or malignant lesions, but it could include debridement depending on the extent of the repair. And again, we don't determine whether it's simple, intermediate, or complex repair. Your provider determines that by how much he needs to repair or how deep he needs to go. But if he doesn't tell us that it's a complex repair, we can only assume it's the lower one, which again, if that is done, then we are losing reimbursement for our provider and it does not support the documentation, or the documentation would not support the code. Listing services for wound repair. Repaired wound or wounds should be measured and recorded in centimeters. Sometimes they have to also let us know whether it was curved or angled. When multiple wounds are repaired, you add together the lengths in the same classification. So if you had 3 simple wounds, you'd add all 3 of those lengths up, or intermediate and complex, and from the same anatomic site. So if you had 3 simple wounds on your arm, you could add those 3 up. If you had 2 intermediate on your chest, same anatomic area, you would add those up. When wounds of more than one classification are repaired, the more complicated repair would be primary, less complicated repair would be reported second, with a 59 modifier. Debridement is considered a separate procedure only when Gross contamination requires prolonged cleaning or when large amounts of dead or contaminated tissue need to be removed. Wound repair involving nerves, blood vessels, and/or tendons should be reported under the appropriate system for repair of these structures. And again, that would, when you do those repairs, it includes the primary procedure unless it qualifies as a complex repair. And then again, we would assign a 59 modifier. After the integumentary system is the musculoskeletal system. And here we have a lot of fractures. Fractures can be closed or open. Closed, it does not protrude through the skin. And open, it does cut through the skin layers, so it can be visualized. We have closed treatment, manipulation, open treatment, or percutaneous skeletal fixation. So a closed treatment, again, it's not open or we can't see it, but they can do a closed treatment without manipulation, with manipulation, or with or without traction. So if they do an x-ray and they can see that the bone is broken, but the bone is not out of line, they could just put a cast on it and that would be considered closed treatment without manipulation. But if that bone might be just a hair off and they want to try to push that bone to line it up straight before they put the cast on, they're going to go like this or however they do it. And that would be closed treatment with manipulation. And then, of course, the fixation would be pins or screws. That's typically done in the OR. We then have maternity care and delivery. And when we talk about maternity care and delivery, we have antepartum care, which is initial, subsequent history, exams, weight, blood pressure, fetal heart tones, urinalysis, monthly visits up to 28 weeks, bi-weekly up to 36, and then weekly until they deliver. If they are visits not pertinent to the pregnancy, they would be billed separate. Delivery includes admission to the hospital, the admission, history, and physical, management, uncomplicated labor, vaginal delivery with or without forceps or episiotomy, or cesarean delivery. Anything that would end up being complicated would be billed in addition. Your postpartum care includes hospital and office visits after either a vaginal or cesarean delivery. Your CPT guidelines for your radiology section, same procedure as the surgery section. Again, x-ray, ultrasound, MRI, nuclear medicine. It's broken up into subsections: neck, chest, pelvis, upper and lower, abdomen, obstetric, so forth. And then what type of procedure? Ultrasound, MRI, etc. In addition to radiology procedures, codes are included for physician supervision and interpretation. So with regards to that, I'll give you an example. We're an orthopedic office. We have x-ray equipment in our facility. Our orthopedics can read regular knee x-rays, wrist x-rays, shoulder x-rays, but they can't interpret spine x-rays. So if we do a knee or shoulder x-ray, our physicians can read them. So when we bill the x-ray, we bill the entire thing. We bill for our equipment and we bill for our physician reading the x-ray. But for the spine, our doctor doesn't read them. We have to send them out to a radiologist. So we would bill the CPT code appropriate for the spine with a modifier TC, which means technical component. It means we are only supplying the equipment. That allows for the radiologist who is reading it to bill the exact same code that we do, but with a modifier 26, meaning he is only providing the interpretation. And the technical component gets reimbursed at 60%, and the professional component gets reimbursed at 40%. So if you do the whole thing, you'll get the full 100%. But if you only do the TC, you need to bill that technical component or the professional component. Pathology and lab section, same way to look things up as the surgery section. There are organ panels, disease panels, drug testing, suppression testing, urinalysis, microbiology, anatomic pathology, cytopathology, and surgical pathology. So again, organ panels are numerous tests that are performed. So for example, it would be like a complete blood count where they're checking white blood cells, red blood cells, hemoglobin, and hematocrit. And in the CPT book, those panels list all of the components of that particular panel. There are drug testing for qualitative and quantitative. Quantitative is done to determine the amount of the drug present. So again, if this type of testing is being performed, we need to know because it's going to make a difference on the codes that would be selected. CPT coding guidelines for the medicine section. Variety of therapeutic procedures and diagnostic testing, dialysis, ophthalmology, acupuncture, chiropractic manipulation, conscious sedation, just to give you a couple. Immune globulins. When you code for administration of immune globulins, we have to identify the product administered and how it was administered. There are hydration codes, IV fluids, IV electrolytes. When multiple drugs are administered, we need to report the service or services and specific materials or drugs for each one. Vaccines and toxoids, immunizations for these. There are codes for the administration and the codes for the medication. So these codes identify the vaccine product only, the vaccines and toxoid codes, but you also want to make sure that you use an administration code to cover the injection. So one for the injection, one for the medication. Home health procedures and services. These would be used by a non-physician healthcare professional only. So this would be a patient's resident, assisted living, group home, private home, custodial home, something along that line. So again, this may or may not be something that your provider would perform. We then have what's called a HCPC manual, Healthcare Common Procedural Coding System. These are, they have 5 alphanumeric digits. It begins with 1 letter followed by 4 numbers. There are also modifiers in the HCPC book, which are 2 alphanumeric characters. Like the modifiers for your CPT, these modifiers also can, they don't change the description of the code, but they provide more information. So for example, a HCPC modifier of FA tells you a specific finger. So it does digits and toes. And when we do certain procedures, we have to let them know what finger or toe we might be working on, or which eye or eyelid, for example. We use the HCPC book the same way. It's divided into 2 parts, alphabetic and tabular. So again, we look it up in the alphabetical index. We then confirm the codes by looking in the tabular list and reading the description. The steps for HCPC coding are almost identical for the CPT Category 1. Clinical documentation is the starting point for your HCPC codes. Sometimes HCPC codes are used along with CPT codes. especially in the office visit setting, because you may be providing a brace in addition to an office visit, and a brace is something that is in your HCPC book. It is not in your CPT book. It is considered a supply piece of durable medical equipment. Walkers, wheelchairs, crutches, braces, anything like that would be in your HCPC book. It also has conventions, so you'll see little symbols and what they mean. In your HCPC book, again, there's guidelines. There's A0021 to A0999. These are codes for ambulance transport. These codes may require specific modifiers for specificity. And we also have codes for medical and surgical supplies, A4000 to A8999. So these can be like splints or ACE wraps or additional, casting supply. We cannot bill for material that was given to us. We can bill for material that we have purchased and that we are supplying for the patient. So if you look down at the bottom of 301, there's some E codes here, which happen to be for humidifiers. On page 302, this table up at the top shows you the modifiers that would be used for ambulance transport. So they would use a modifier P, for example, if they pick the patient up at their residence, because they are billing to the insurance company that transport from the residence to the facility or the hospital. Again, durable medical equipment, E0100 to E999. Again, I just mentioned, but your crutches, your walkers, your wheelchairs, anything like that that assists patients with mobility. But again, you need to have purchased the material in order to bill for those materials. If you look on 302, in closing, your CPT and HCPCs are updated and published every year. So again, make sure you are using updated manuals. You can order them in the early fall, and they begin in January for your HCPCs and CPT. Again, always use current year manuals so that they are current and accurate. Medical assistants are responsible for keeping up to date on CPT coding to help ensure no fraud is taking place. Medical assistants also should ensure that proper precautions are taken to avoid incorrect coding, data entry error, and false claims submission, because that may be considered fraud. So again, if it's not documented, it was not done. We want to make sure our documentation supports the code that we are billing. Medical coders should be familiar with the NCCI edits. These are also published every year by CMS, Centers for Medicare and Medicaid. And you can be cited by Medicare for fraud or abuse, or both, if you frequently unbundle those codes. So I mentioned earlier, you try to bill individually for everything you are doing, when indeed there is one code that includes it all. Not only is unbundling unethical, it can have monetary penalties. So they can be, your practices can be cited for penalties of up to $50,000 per violation, and assessments of up to 3 times the amount claimed for each item or service. So this is nothing you want to mess with, because per occurrence, or per violation, once they find one fraudulent thing, they're going to keep digging. They're not going to just leave it alone. So that's why you don't want to do it. I can't ask if there's any questions. I apologize, because there's nobody out there logged in. So what you will want to do is, again, take your chapter 15 exam in the book. If you have any questions while you are going over this with regards to procedural coding, please let me know. There have been times in the past, and I think I mentioned it before, where sometimes the answers on the exams actually mark it as incorrect when it is indeed correct. If you ever have a question like that you feel is wrong, that they've given a different answer and you think your answer is right but they marked it wrong, cut and paste me a copy of it. I can look at it and double check it. Again, like I said, some of them mark them wrong when indeed they are correct. If that is the case, then I can have that changed for you. Or if it's not the case, I can explain to you the reasoning why they chose the answer that they chose. So if there's nothing else, next week you have off. We will resume January 3rd, and we will be doing or attempting to do chapters 16 and 17. As before, we will get as far as we can get in the hour and a half and then pick up, but we'll be talking about the basics of health insurance and medical billing and reimbursement. So, with that, we are all set. We'll take a quick break before the billing class, and I hope everybody has a wonderful holiday. And again, I will be around all during the break, so if something does come up, please shoot me an email, send me a text, and I will get back to you as quickly as possible. All right, happy holidays. Thank you. All right, I'm going to go ahead and get started on the billing. We left off last week on page 347, so I'm going to try to finish this chapter and then start chapter 11, which is talking about Blue Cross private and managed care. And next week we do have off for the holiday, so please make sure that you get caught up to at least that point. And when we resume the first of the year, we should be able to pick up with chapter 12, which is Medicare, and then move into the main care programs. Kim, I did get your email with all your questions about chapter 9, and I will be working through those and getting back to you on a reply before you take the exam. So we left off on collections. So there are different types of collection letters. Can be a form letter to save time. It should go out automatically at certain times of your billing cycle. It should have the full amount owed, the services, what action the patient needs to take, how long they have to take that or respond, how they can take care of the bill, why they should take care of the bill, where they can send payment, a phone number to call if they opt to call, contact person name, and a signature of somebody who is sending the letter. When you pursue collections, you do want to stay within the authorization of the physician. All letters should be noted on the back of the financial accounting record or in an accounting log or in the computer in a comment area so that you know that that account has been sent to collection or you've talked to the patient about it or something to that effect. Letters can be sent in colored envelopes, address service requested. Some people will send them certified mail return receipt requested so you know that they've received them. There are some collection abbreviations you can use while you're documenting the efforts when you speak to your patients. So again, if you are having them, table 10.3 in a couple of pages shows some abbreviated abbreviations you can use. Most patients have insurance. However, filing a claim is the first step. Good follow-up techniques are necessary. So if we submit a clean insurance claim with all the prior authorizations or referral, if we do not hear, next follow up in a timely manner. We can check our electronic submission reports to make sure that the insurance company has received our claim. If the third-party payer seems to be ignoring efforts to trace the claim, an exact history of the account can be the best weapon to proceed. That's a chronological record of all the events that have occurred. Keep your communications from third-party payers. Note your telephone calls, copies of all documents sent. Our system will document when the payer acknowledges receipt of the claim and then when it gets processed. So if they say they never got it, we can actually submit proof that they acknowledged receiving the claim. Co-insurance payments, use a letter or a statement to collect from patients who have insurance coverage. Make sure that we are letting the patient know we've submitted to the insurance and this is patient responsibility. And we try to submit those bills to the patient for their responsibility as quickly as we hear back from their insurance. So if there's a delay, if February claims, you fight with Anthem until September to get them paid and there's a patient balance and we're now sending the patient a bill for services in February, a little note or a phone call to the patient saying your insurance company just paid, this is why you're delayed in getting your statement. If not, they'll call you and just be prepared. But there can be notes on your statements We have received payment from your insurance. The balance is your responsibility. Your insurance company paid their share. This is your responsibility. Your insurance company has paid blank. Remaining portion of is your responsibility. Balance is your share of the cost. Your insurance company has not responded. Account is due and payable. Contact your insurance company about payment. Thank you for your assistance. So you can throw it back to the patient and have them also get in touch with their insurance carrier. There will be sometimes, you can see up at the top, there's a collection form letter, and there's a multi-purpose collection letter with a checkoff list that could be used. Hi, Kim.
Hi.
I just started, but I'll let you get your stuff out and then I'll
Thank
resume.
you. Sorry, I had to take my husband's truck, and it's the first time I've driven it, so
Oh, really?
I didn't know quite what I was doing. So.
That's okay. I got your email, so I am working through those questions, and then tomorrow I'll send you a reply to each one.
Oh, thank you, because I know when I took the CMAA course, I know one of the exams I took, there were a couple of questions, and it turned out that I was right, and there was something with the book.
Yep.
But I know one of them, I know I got it wrong, but I do not understand why I got it wrong.
Yeah, and that's fine. That's why I want to look it up and then get back to you. But we had meetings today, and then we had a Christmas party at work, so I didn't even have time. But I at least printed it off, so I will do that before you take it. Yeah. So I'm on page 349, just getting ready to talk about insurance checks sent to patients.
Okay.
So we'll pick up here. I said at the beginning that we'll finish chapter 10. We'll go on to chapter 11, which is the Blue Cross private and managed care plans. And if we get a chance to start chapter 12 with Medicare, we will. Otherwise, we'll start the Medicare chapter the first of the year because, as you know, next week is the break. So you'll just want to make sure that you're caught up before we come back in January, up through and including chapter 11.
Okay.
All right. So insurance checks can be sent to a patient. So if when you're doing follow-up on your claims, if you call the insurance company and they say that the payment was sent to your patient, you want to follow up on that right away because a lot of times patients will get a check and they could think it's for overpayment for their premium. And they're going to cash the check. They don't always realize that it's for services for the provider. Yes, payments should be mailed to the provider directly, but in some situations, especially if the provider is not participating, checks will go to the patient. So the quicker you know the patients have gotten the checks, you can follow up and say, you know, your insurance company has said the check was mailed to you. This is the amount due to us. Please remit, or something like that. You cannot send, you don't have to, I should say, continuous monthly bills. If they refuse to pay and they've received the check, you can send a 10-day notification that if payment is not received, the account will go to collections. When they're talking about collections, they will tell you to follow collection protocol for your state. Your state will tell you certain times when you can call and that type of stuff. But they tell you that if you threaten collection, so if you call someone and say, if we don't receive your payment by Friday, your account will go to collection. If you don't get that payment Friday, you need to send that account to collection. You don't give them until Monday. So,
and you don't let the insurance company know that the patient has not paid you, so that they're aware of it?
No, because the insurance company paid their portion. The patient's responsibility, such as their co-insurance or whatever, if you send that to collection, what can happen is the insurance company, when they go to renew that policy, if they check the patient's credit, that's when they will see that it will pop up.
Okay.
People use
Because I was thinking that there's not really an incentive for the patient to pay the provider if.
Right. Yeah, it used to be that people thought that medical didn't appear on your collections, when they checked your credit, but that is false.
Right.
It does appear on your credit. So, yeah, so they definitely would know. On page 350, I mentioned, I think right before you came in, when you're doing collection calls, if you're starting that process in your office, there are a list of abbreviations that you can use when you're making notes when talking to patients. Just make sure that you have a list of what those abbreviations are, so if somebody comes in to do collections, then they are working off the same abbreviations that you do. You can see the next couple of pages, it gives what to do in the scenario if you were dealing with somebody that had a managed care organization, or if you look at 351 under Medicare, it says a provider must make genuine efforts to collect deductible and co-insurance, reasonable efforts, subsequent billing, telephone calls, and in-person collection efforts. As with all patients, accounts may not be written off until sequential statements have been sent or collections. So typically they will tell you that 3 statements is enough, and then some people will send that 4th statement that says this is it, and others will say the 3rd statement is it. That's going to be, up to your practice. Suing a third party payer. So there are statutes of limitations to which there are time periods to where the insured person can sue the insurance company to collect the amount that they think they're due. They have until 60 days after the initial claim has been submitted. And if it's a lawsuit, it's 3 years of the date on which the initial claim was submitted for payment. Again, if they're going to do a lawsuit, they want to make sure it is worthwhile and that it's a high dollar claim. If you look on page 352, an uninsured person is entitled to appeal a denied claim under 2 federal laws. Timely request needs to be made within 60 days of denial, and then the time limit would be within 6 months. And again, it's got to meet medical necessity, not a pre-existing condition. These are all things when it is based on that type of denial. What I like to do is keep a log so that I know the time periods that I have to deal with, like for appeals, or if a patient calls and says, how long, do I have before I can call the commissioner and complain about the insurance company not paying my claim, because there are strict guidelines, and if they're not met, then that's it. I mean, they won't even relook at your claims, so you can tend to lose reimbursement. When the claim falls outside the scope of the federal laws, it is possible to sue, but it depends on the conduct of the payer if they're violating the state laws. So again, suing becomes a whole nother issue. Collection agencies, when you have delinquent accounts, when you've tried everything that you can try, if you do not have a department in your facility that does collections themselves, then you can turn it over to a collection agency. When a patient states they're going to pay and they don't pay, when they break a promise to pay. So if somebody's put on a payment plan and they agree to $100 a month and they pay it that first month, but then the next month you don't get a payment, they broke that payment plan. You can actually, if you have a signed agreement that we talked about them making those monthly payments, you can automatically send that account to collections because they broke that. Partial payments, and there's 60 days with no payment. They don't respond to letter or phone calls. You get checks for non-sufficient funds and they reissue you a check and it happens all over again. Anything like that, they may give you false information. When a patient is paid by the insurance company and they don't forward payment to you, you can send that to collection. The insurance company paid them the money, they owed it to you. If they're not paying you, you can send that to collection. Not all accounts should obviously go to collection, and that could be people living on pension, widows, people on restricted incomes that might fall under poverty level, financial hardship, something like that. There will be times when you might have a patient with a $10 balance. We have accounts if it's under 10 and we've exhausted all our efforts, we're not going to use a collection agency for $10. That would be written off as a small balance write-off. If it's between $10 and $40, then that might be written off as a bad debt. It's not enough to send to the collection agency because the collection agency is going to keep the majority of the money. So let's try to just write it off as a bad debt. And if they resurface and come back, they have to pay that amount to get in the door. And then anything over 40 goes to collection. But when you are choosing an agency, you just got to do research. You've got to look and see what their process is for collecting, how much they've collected, what their fees are. Make sure you set up a separate post office box for the collection, or a separate bank account if that be the case, or have funds go directly just to the collection agency. If you're paying the collection agency a flat amount per month and you're not seeing money come in from those collection accounts, what is the collection agency actually doing? They may not be doing anything. Maybe they didn't get to it that month. But if you're paying them only a percentage of what they actually collect, they're going to definitely try to collect for you, because if they don't collect, they don't get paid. So depending on what percentage they're getting, you want to do some shopping around. Types of agencies, there's local, regional, national. Again, just do your research. We use one actually out of New Hampshire. We don't use a local one. So another option is to use a collection service, CollectNet. It gives small, mid-sized facilities collection capabilities of larger companies. Again, whether or not that would work for your practice. Agency operating techniques, so you can look and see they have to follow all the rules of the Fair Debt Protection Collection Act. So if there's been issues, complaints about them, we would be able to see that. Again, check the agency charges. Some will be a flat rate. Others are paid on commission of the percentage of the account that they collect. Some are on percentage of the account, and the physician's office refers all calls to the agencies once they're turned over. So they don't let the patients pay the office directly. Everything's got to go through the collection agency. And again, make sure the commission is based on how much was collected. Agency assigned accounts. Again, patient's accounts turned over to an agency should have a letter of withdrawal sent by certified mail. There should be a note on the financial records on the date that that was done. Once an account's been given to collection, it's illegal to send the patient a monthly statement. So they can call and they can ask for a printout of their history, but you cannot continue to send them a monthly bill once they've been sent to collection. So there's got to be some way in your system to shut that off. Each patient account that's been sent to collection should have an alert every time the file is opened. just so that you know something is going on with it. Like, for example, if the patient made a payment to the office, we need to let the collection agency know. So somehow it's got to flag somebody so we know to let the collection agency know there's a payment. If not, the collection agency is going to keep doing their thing, and when they call the patient and say, you owe us $150, they're going to say, nuh-uh, we went into the office last week and paid it. Well, that can be the case, but then you're going to get a call from the collection agency verifying that information. So if you have a process, it just makes it better for you. Small claims court, it's part of the legal system, allowing you to collect money. Most states have small claims court. Dollar amounts vary from state to state. The national median small claims is $5,300. New limits in certain states can be $3,000 to $25,000. So again, make sure if the physician decides to file a claim, the person filing the petition or the person in the physician's office is called the plaintiff, and the party being brought to suit is called the defendant. And there is a step-by-step procedure for filing a small claims court. So that is something that you could have in your policy and procedure manual if that were to happen. So the defendant has 4 options once they're served: pay the claim, ignore the claim, answer the petition, or demand a jury trial. So again, if they go to trial, plaintiff and defendant have to appear. It tells you some things that, to prep for the trial, be on time. Otherwise, it could go either in the defendant's way, or if the defendant's late and you're on time, it can go your way. Make sure you have all the information that you would need to submit if they ask for it. Show all dates of service, all amounts due, date of last visit, date of last payment. Show all the attempts to collect the debt. So your, chronological or your notes from doing that, the timeline. Speak slowly, clearly, answer all questions accurately. Witness if it's a live testimony or a notarized statement. And try to anticipate opposing party evidence. In the way too many years that I've been doing this, it's never gone to Smalls claims. Our procedures aren't, they're expensive, but they're not that expensive after insurance. So, some of the higher price surgeries, it could get to this point. Just know what your steps are. Federal wage garnishment law. This provides a limit on the amount of earnings withheld in a work week or pay period when a debtor's future wage is seized to pay off a debt. So again, this can be one result of going to court. They can garnish their wages and make sure that X amount of money out of their paycheck is being sent to you directly to cover that bill. Tracing a skip. Patient who owes a balance on his or her account and they move and leave no forwarding address is called a skip. Typically, in that case, you're going to get an unopened envelope that says return to sender, addressee unknown. If that happens, you can always try calling the patient by the number that you have in the system, get a different address. If their number's been disconnected, we might try the primary care to see if they've been to them and have a different contact information. You can do the forwarding address requested. So if they move for up to a certain period, they'll send the thing back to you with the updated address. There is a cost for that, so depending whether or not you want to use that. But periodically you will have a skip. If you look on 356, search techniques used to trace a debtor. So they're telling you to look at the address, check the patient registration form, check the zip code, file a request with the local post office to get the new address. Again, call the PCP like I just mentioned. You can check at the hospital in their system to see if the patient's been there recently, maybe with a new and updated address. Anything like that. Sometimes you can request the local credit bureau to see if they have any current information on the patient as well. So once you know a patient is a skip, trace it immediately. Make sure you have office policies establishing how that skip is going to be traced. So again, just having that protocol in place, like up above. I'm going to try the piece, I'm going to check the registration form first. I'm going to call the patient, the number that we have on file. I'll check the PCP, what your steps are. There are several outside services as well that you can use. Again, collection agency, credit bureau, something like that. You can search via computer. Sometimes that will work. You can use a surname scan locally, regionally, nationally, address search, or property search, credit holder search, phone number search, neighbor search, zip code search. Some of them, might get you a needle in a haystack, but it might help, may give you some information you didn't have. Collection issues, bankruptcy. These are federal laws. They're applicable in all states. There's two kinds of bankruptcy petitions, voluntary and involuntary. The voluntary is filed by a person asking for relief under the Bankruptcy Act, and involuntary is one filed against the person by his or her creditors. So when they file for bankruptcy, they become a ward of the court and has protection. Patient is granted an automatic stay against creditors, which means the physician can contact the patient only for the name or address of their attorney. You can't call them and harass them about paying their bill. So again, that means you should probably take them off the statement list or the phone call list. Bankruptcy rules, 2005, debtors have to meet an income test and must have insufficient assets for a Chapter 7. Otherwise, it's a Chapter 13. So when they file a claim, there'll be a proper form that will be filled out. It will be sent, that form, to you. And if you are able and want to submit, depending on the type of bankruptcy they're filing, then you can fill out or submit before the dates that's on the form your information about what they owe you, and then they will take that into consideration when they settle their case as to how it's going to be paid. If you don't send anything back when you get that notification, then your charges are not going to be considered, and you end up writing off that cost as a bankruptcy ruling, and you can't collect it. Terminally ill patients, of course, it can be harder to collect from patients. They may have estates after they have passed, but when a patient is too sick, you may ask to speak to family members. Depending on the balance, it may be something that's brought to the physician or the practice manager's attention and kind of go from there. Estate claims, again, is for a deceased patient. So just because they're deceased doesn't mean you can't try to collect from the estate. Typically what would happen is, if they're deceased and your statement has already gone out, somebody's going to get that statement when they're cleaning out, and you either get a call stating, I'm sorry, there was nothing, there was no will, whatever it happens to be, or I'm the daughter, I will be taking care of the estate as soon as everything is settled, we will be taking care of your bill. So a couple of different things that can happen. And you can always check with the county court in your state about filing deadlines for state claims as well. Litigation. Go ahead.
Yeah, good question. So, okay, for example, because there are a lot of patients in our practice that are obviously Medicare patients, they're older patients because they can no longer take care of their feet. So I do get, I field a lot of calls from patients family members who've gotten reminder calls that mom or dad has an upcoming appointment, and that's when we get a call saying, oh, mom has passed, dad has passed, and I, apologize. I'm sorry for your loss. Any of those that still have outstanding balances, I never say anything during those calls. I just say, oh, not a problem. I'll put a note in the file, and I will definitely let the doctor know, because I know that he'll want to know, and hang up the phone at that point. Now, with those patients, we have the process for taking care of the chart itself, but if they have an outstanding balance, I mean, if it's an outstanding balance of $10, that's not relevant. But if there's a patient that has a larger outstanding balance, like, maybe like $100 or $120, something like that, because they've had a few that just maybe they had gotten ill and they just hadn't caught up with those payments. How normally we have a power of attorney on file, or we have an emergency contact. Do we wait? I mean, is it because it's one of those moral things too? Do you just wait a couple weeks and then send a statement, or how?
Well, I think it depends on your practice. If you've been notified by the family member and you flagged your chart, typically what I might do at that point is look at the account and see when the last statement was sent out. If the last statement was sent out recently, chances are maybe they haven't gone through it yet, and I'll give them a couple of weeks. If they're due to get another statement because it's almost been 30 days, then what I may do is just do a courtesy call to that family member or power of attorney and just say, we've been notified, that your mother has passed. We do have an outstanding bill. If there is an estate, would you like us to send a copy of the statement so that it can be put in for payment? And typically from there, they'll either say, oh, yes, we haven't done that process yet, or we did come across it, we've already got it. Or if they say there is no estate, depending on your office, some of the offices, especially, here we go with the amount thing again, and this is why you got to have a policy in place. If it's a larger amount, you may require that they send you a death certificate or a copy of a death certificate. I had to do that with my dad. When he passed, he had nothing. But he didn't make any of us power of attorney either, and he was living at my house, so the bills just kept rolling in and rolling in.
Okay.
And when I would call, because I'd send it back saying deceased, but they'd still send it because they wanted their money. So I'd call and I'd say, there was no estate, he had nothing, he had his retirement check, we paid for his funeral, I mean, there was nothing. And in order for them to clear the accounts, they required I send a copy of a death certificate. Once they got the copy of the death certificate, then they wrote off the amounts because that was their protocol and that gave them the okay to do it because there was no estate.
Okay.
But if you want to have those things, like you said, have something that says if it's under a certain amount, when they call and let you know about the death, then whoever takes that call is going to let your billing department know so they can do whatever they need to with the balance. If it's between this amount and this amount, have a process in place for that. But, look and see when the last time they got a statement was. If they tell you they just passed yesterday, then I might give them a couple weeks.
Yeah.
Yeah. But you got to make sure
I was just wondering because now I'm on this side of the desk as far as being, that difference between patient and healthcare worker. I can see things on both sides, and I think, well, okay, as if it was me, I'd be like, oh, all right, I understand you want to get paid because I understand how all of it works now.
Right.
Where I can't imagine, it's like trying to imagine someone that does not understand how the healthcare works. So, well, these people still need to be paid. Like, you don't want to offend anybody or unduly upset them, especially at that time when there's been a death in the family. It's like, how do you balance that? And I know that my bosses, they're like super nice people, and I know they've written off so much more than any other small or large practice would, just because they're nice people.
Right.
And I'm thinking they really need to start, we've all kind of urging them to start, it's okay. No, just push it to the patient. No, let's not. This is the fourth call to the insurance. Let's just push it to the patient and let them call the insurance, like that kind of thing. So that's why I wanted to kind of understand that, because I know we have, and he started going back and seeing nursing home patients again.
Yeah.
So that's a whole nother new thing that's going on there.
Yeah.
And there's a lot more chance where you're dealing more with power of attorneys, and I'm doing a lot of calls to patients' children who live in other states because they've called and left a message because they've received a bill and they have no idea why they received a bill.
Right.
And I'm like, well, that's because you're listed as the person to deal with this, but mom can make her own decisions. Well, then you shouldn't have a power of attorney stating that she can't make her own decisions.
Right. Exactly.
So it's that new little world, and that one is the one that I was the most, like, I haven't had any problems in explaining bills to patients and talking to people about that, but I've seen like I've had those phone calls where patients passed, and I'm doing what I need to do to let the system know that the patient's passed, but then I see balances and I'm like, okay, well, that's billing department, I can't touch that, but I'm looking at that. That's kind of that's a decent enough amount.
Right. And if there's an estate, that's what it's there to do. Take care of outstanding stuff, and then it takes care of, the rest of the family. But just make sure that you set the limits. So anything under this, you're going to write off. If it's, above this amount, then we'll give them their grieving period, but then, and maybe you've got the power of attorney, so maybe you send that power of attorney a copy of the statement with a note on it. You print it off and you put a handwritten note. Sorry for your loss. This is what was due after insurance for your mom. Please let us know if there is an estate that will be taking care of this, or call if you have questions. Sometimes it's just that little handwritten note, And yes, it takes time, but if it's going to get you that money, it's better than writing it off.
Yeah.
So, litigation obviously can be done. Liens can be put up against property. Again, this is going to all depend on amounts. Physician can be asked to accept a lien by the patient's attorney when they've been involved in an automobile accident and they're awaiting settlement. Liability cases are awful because sometimes you can wait for settlements forever. So practices need to determine whether or not they're going to accept liability cases, because if they do, then they're going to be on your books for a while. If they're not, your patients are responsible for making those small payments until the case is settled. Oh, excuse me. If patients complain, you want to resolve it quickly. Billing disputes, address collection complaints seriously, listen with an open mind. Patient can refuse to pay the physician if you do not address their complaint. So again, listen carefully or read a letter if they've submitted a letter. thank them for calling or writing, apologize, whether it's right or wrong, answer the complaint, use a professional, sincere approach, take all complaints seriously, respond to a letter, be cordial and sincere, follow up after the complaint has been resolved, have steps in place that, you may be the one that's able to resolve that, or if the patient's complaining because he's unhappy with a physician's service, he was in the office for 5 minutes and you're billing him $200, there's no way he's going to pay that. Okay, I understand your concern. I'm not the one that can address the situation for you, but I will print off the information, forward it to the provider or the practice manager, and let them know that you should be hearing from them. If you don't hear back from them, give me a call back and I'll follow up on it. That way they feel like, yes, you're gonna get something done for them. Hopefully you don't have too many complaints, but bonding, insurance billing specialists, claims assistance professionals, anybody who handles checks or cash should be bonded or insured. And typically this is something that your provider takes out insurance on you, unless you are an independent contractor and you work from home. Then you want to have some type of insurance that's going to cover you, especially if you're dealing with payments and having the money. But otherwise it would fall under your physician. And on 360 it lists a couple different types of bonds. Position scheduled bond, which covers a specific job, a blanket position bond for all employees regardless of job title, or a personal bond just for those handling money. Some issues, embezzlement, stealing money that's been entrusted. Sometimes it can take a long time for that to be discovered. Other times it can happen pretty quickly. So to prevent the temptations of stealing, there should be office policies that are practiced. Physician or supervisor must approve all entries about adjustments, discounts, and write-offs. So I'm the only one that can make a write-off on a patient's account. Not anybody can just go in and adjust $10 off because it's their neighbor. So I'm the only one. So if there's a write-off, it's coming back to me. But that way, there's one person that can account for it. And I've got my documentation when something is written off. There's a note why, per physician, or, patient deceased, whatever it happens to be. Mm-hmm. So there has to be a daily trail of the balance. So when your front office checks out at the end of the day, they should be able to balance how much money they've taken in with what they are giving whoever is taking care of the deposits. So if they've taken in $500, there better be $500 when they hand that over. If there's not, that person needs to be accountable for that. They cannot hand it in until they've got that money. And it does happen that, things might stick together or unstick and they counted wrong and it doesn't work out. I had the other day, they told me $500 had been posted, but yet I only had $300 at the end of the day. So when I went up and said something to that person, I said, you put that your end of day balance, but it says here 500. What's this? This is only 3. I said, where's the other 200? Well, it must be in my drawer. So we looked, not in the drawer. Well, after thinking about it for a while, she realized that the person was going to pay $500, only had $300 with them, but she posted it as $500, but it didn't balance. So I had to go in and void that payment and then re-enter it as the $300 and make a note as to why it was done that way, because it looked like her draw was short. Sometimes I would call the patient and verify. If it's a significant amount, I'd say, we have a payment received from you today. The computer says you paid $500, but I only received $300 from the front desk. And he did. He said, no, I only had $300 on me, but I wanted to do $500. But if he had said, no, I paid $500, then I know who I'm going, I got to go back up and say, right. They said they paid you $500. Where's the other two? So,
yeah, I had to explain that to one of the staff. I had the reverse because she was sitting there trying to organize from between, like, I handle the lunch up till lunch, and then she handles after that. So she was going through and making sure that the Dan report that we're working on for that day, she was like making sure all the receipts had everything written on them. And she was like, okay, why do you have 2 receipts for $25 for this same patient? And I said, because the patient came in and had the money for $25. She thought her copay went up $5 and was now $25. After calling the insurance and verifying her new insurance card, it was not $25, it was $50. And I gave her the option. I said, I understand, because I was on the phone for quite a bit with her insurance trying to get the correct answer.
Figure it out.
And I said, it's okay if you want. I said, you've paid the $25. I said, we can always send you a statement for the other $25. And she goes, no, I'll go home. I'll bring it back. I said, all right, you don't have to, but okay, because the weather was and she came back, so I had 2 for $25. So it looked weird.
Right.
And I said, yeah, we might get a question about this. I said, but because she left and came back, I felt like it had to be posted as 2 separate entries. Even though it was $150 copay, I needed to show that she paid twice. That way, in case, because her husband is the one that I know her husband's the one that does the bills, he would call and be like, what the heck is going on? And I would have that ability to tell him she had this, and then she came home and came back with the other amount, and that's why it's showing up that way.
Right, and she did. She made 2 payments of $25. She didn't make 1 payment of $50. So you did it absolutely right. So if you receive an insurance payment check, they should be immediately stamped for deposit only. You don't want to leave them laying around. Encounter forms, cash receipts, pre-numbered, so that you make sure if you're seeing 50 patients, that at the end of the day, you're accounting for all 50, encounter forms, whether there's a copay, cash, credit card, whatever. Put your initials at the bottom or the top corner if you're submitting the claim form. Now they go electronically, so it's already tagged. If you're the one entering it, it's, you're the one that's logged in. Okay. Again, petty cash, use of computers, so that's part of protection against embezzlement. You can see on page 361, 7-step billing and collection guide, and then on 362, a collection plan. So, again, those steps, how to deal with a patient. The small claims court that we talked about in 10.4. And then 363 up at the top. So this is a letter confirming telephone payment discussion, and it's sent to the patient reminding them. So they agreed to pay $100 before October 15th. So they're sending this out, reminding them. Whether or not you send a letter, when I work my collection accounts, if I'm calling them on the 2nd and they're telling me that I'll get the payment by the 15th, I don't really do a letter, because by the time you do it, you mail it cost-wise. Yeah. So I'll put it on my collection report, and I'll call the patient on the date that they promised to pay, and just let them know that we've received nothing by mail. If they want to pay for it over the phone, then it will avoid that collection status. Otherwise, if it's not posted by the end of the day, they broke their agreement. So a couple of different ways. So that is it for office and collection strategies. So on to chapter 11, which is Blue Cross, private insurance, and managed health care. So we'll talk about the differences in the plans, talk about the HMO Act, features of an exclusive provider organization, preferred providers, point of service plans, quality improvement organizations, a whole bunch of stuff. So, private insurance companies, there's all different kinds of them. Most of them offer a variety of managed care plans. However, with the Affordable Care Act, significant changes from fee-for-service medicine took place. So there's a difference between private insurance and managed care. Fee-for-service reimbursement we've discussed in previous chapters. However, this chapter will go into managed care capitation as a form of reimbursement, and most of the places don't even do capitation anymore. So I'll let you know what it is so that you're aware of it, but most of them have gone to just strictly a fee schedule and not the capitation anymore. So Blue Cross Blue Shield is the pioneer in private health plan. It's a private insurance carrier, has been for many years. They're the largest insurance company in the United States. Each plan independently owned and operated in each state. Identification number consists of 9 to 12 numbers and 1 to 3 alpha characters. They can have a traditional plan, a managed care plan, for example, a PPO, preferred provider organization, POS, point of service, IPA, independent or individual practice association, HMO, health maintenance organization, Medicare HMO. Nationally, Blue Cross is a single corporation administering rules and regulations for the regional plans to follow. So as an experienced insurance billing specialist, we need to be aware of problems that insurance companies or circumstances can cause. So, for example, getting the wrong policy number can require the claim to be sent to the home plan or sent to the provider's state plan. Typically with Blue Cross Blue Shield, if you look on the back of their card, it typically will say whether or not they want you to send it to your local Blue Cross plan or if they want you to send it to their individual state plan. And that's what you need to do. If they want you to send it to your local Blue Cross carrier, then make sure you're putting it in under your local Blue Cross carrier. They want it to go to your state plan.
Right. So if it's Blue Cross Blue Shield Texas, but then on the back it says please submit to your local Blue Cross, when you're putting them in the system, you have to put it in under Blue Cross Blue Shield Maine because that's where you're submitting it, correct?
Yeah, absolutely. Okay. So that you're making sure it's going to that P.O. Box 533 in North Haven or wherever it's going. Absolutely, yeah. Always verify the mailing address for claims and the address for sending appeals. Sometimes those are not the same. So again, getting copies of the front and the back of the insurance card. There are unique situations regarding contracts with Blue Cross Blue Shields. They like to have contracts with both medical groups and providers that work for the groups. This can cause problems when the group and providers are contracted, especially when the group is contracted and the provider is not. Or when there's no contract with either the provider or the group. Because what if you have a provider that's not contracted in your group and the patient's regular doctor is away who's contracted, so that would be covered, but they're seeing this doctor who's covering and he's not contracted. Now that patient's going to be liable because that provider is not contracted. So being careful with whether you're credentialing or contracting as a group or individual providers. We've come across it a lot because a lot of insurance companies will say we have to credential the practice and then we have to credential each individual provider. Or they'll say, no, as long as you credential the practice, any provider is covered. Well, that didn't end up being the case. The providers had to be credentialed, not the practice. So we ran into issues. But again, with Blue Cross Blue Shield, you would get reimbursement if you are contracted with that carrier. Payments go directly to you, the provider. Deductibles, copays can vary depending on their plan. Medical practice should have available for reference the provider manual for its particular state, or at least have access to pull it up online. You can see on the bottom of this page a couple of different cards. This is all for Blue Cross Blue Shield Texas, but one's a PPO plan, one's an HMO plan, front and back. So they could have different contact numbers. Obviously, they have different copays. Probably, actually, yeah, they got a prescription deductible on the HMO, where on the other one they do not. Managed care. Typically, these are HMOs. In an indemnity plan, it's referred to as traditional insurance, where they pay a fixed month premium and 100% of the medical bills until they reach their annual deductible. Then the insurance company pays a percentage of covered benefits up to a maximum amount. Once they reach that maximum amount, their benefits would be covered at 100% until their policy renews. In a managed care plan, a specific set of health benefits are provided for a yearly fee or fixed periodic payment to the provider. Patient pays a smaller monthly premium, can be restricted to which providers they're able to see. In addition to HMOs, other types of prepaid group practice models are managed care organizations. In the prepaid group plans, the patient joins the plan. They pay a monthly medical premium, individual or to their employer. Physician sees the patient. Patient pays a small copay, maybe a deductible. Providers that join the plan are paid using capitation, which means that they're paid per capita amount for each patient that is enrolled over a certain period of time. So the more primary care patients they have, the more per capita they're going to get paid. They've done away with a lot of the capitation payments because of that. Because what they were finding is physicians would agree to have all these primary care patients, and they were getting paid to see all these patients, but the patients never went to the doctors because they didn't need to have anything done. So the doctors were making money without seeing the patients. So that's why they typically have changed to, you don't get paid unless you see the patient. But know that in places, they may still be out there. Prepaid group health plans, if you look on 371, most Cigna patients are served under a prepayment group plan. They pay a monthly premium, receive hospital, surgical, professional benefits from Cigna staff physician or Cigna Healthcare Center. Several Cigna patients are private. They're treated on a fee-for-service basis. There's another prepaid group plan, Kaiser Permanente. That goes way back to 1933. They now have 12 centers in 12 regions covering 16 states. And they are under a prepayment group plan that receive, again, the hospital, surgical, professional benefits from physicians located at Kaiser Permanente medical centers. It's a closed panel program, so the physicians have to be within that group. So a lot of the prepaid group practices you may not see around our area as well. The HMOs, Health Maintenance Organization, this can be sponsored, operated by the government, medical school, hospital, employer, unions. 73 was when they passed the Health Maintenance Organization. It helped to include providing grants, loans to offset initial operating deficits of the HMOs, meeting certain standards, and requiring that most employers offer HMOs to their employees as an option for health insurance. Accreditation, National Committee for Quality Assurance, it's nonprofit. They accredit all HMOs, including staff, group models, mixed models. So they have to meet certain standards in order to continue operating as an HMO. So that's both state and federal. Those who have voluntarily enrolled in an HMO or who are covered are considered eligible. And the law states that an employer having 25 or more persons can offer an HMO, again, as an alternative insurance for employees. And again, the federal government reimburses HMOs on a per capita basis, depending on the size of the enrollment. But there are qualifications to be an HMO. They have to present proof of the ability to provide comprehensive health care. And to retain that eligibility, they have to render periodic performance reports to the DHHS, so the Department of Health and Human Services. And of course, depending on how periodic they are, some providers may feel that it's too much work to provide those reports to get what little they may get back from that. A primary care physician, or a PCP, is what we like to call a gatekeeper. They control who the patient sees and go from there. If you have a PCP, then again, if you think you ought to see a specialist, but the primary care says, no, that's something I can handle here, if you go see the specialist, it's on your own, it's out of your pocket, because your primary care did not authorize it. You do or are given an identification card, and again, checking both front and back, patient name, member name. What I find hilarious is I can say it 50 times a day, and it still happens every day. When you copy an insurance card and you put patient in the system, how their name is on their insurance card. If their name is Elizabeth, you don't put them in the computer as Betty, because when you try to do electronic eligibility, Betty's not coming up on the insurance end, and that will cause claims to be denied. So again, getting that copy so you are able to check that, and again, both sides. Again, the HMO, the oldest of the prepaid health plans, fixed periodic payments made in advance to participating providers. HMO models, there are differences in the structure of the different HMOs. So again, there's a prepaid group practice model, HMO. They deliver service at one or more locations through a group of providers who contract with the HMO. Kaiser Permanente would be a good example of that. Staff model type of HMO, where the health plan hires physicians directly and they're paid a salary instead of contracting. Network HMO, they contract with two or more group practices. So it's common for these physicians to see both HMO and non-HMO. Direct contract model, open panel type of managed care, contracts directly with private practice physicians in a community rather than through a medical group. Exclusive provider organization, or EPO. Again, it combines features of a health maintenance organization and a PPO, or preferred provider organization. It's exclusive because employers agree not to contract with any other plan. Foundations for Medical Care, an organization of physicians sponsored by state or local medical association. Two basic types of foundations for medical care operations. Comprehensive type, which designs and sponsored prepaid health plans or sets minimum benefits or coverage, and then a class review type of foundation, which is evaluation of the quality and efficiency. And a lot of these types are not ones that you will see locally. They may appear in bigger areas or with bigger, larger, much larger organizations. An IPA, Independent Practice Association, the physicians are not employees. They are not paid salaries. Instead, they're paid for their service on a capitation or fee-for-service basis from a fund that is drawn from premiums collected from the subscribers, union, or corporation. And then they withhold up to 30% to cover operating costs. These types also, you're going to see fewer and fewer of them. I believe Maine Med currently has a IPA, but because of the withhold and making it a lot complicated when people were posting explanation of benefits, you'd periodically see a withhold amount, and that was figured differently at the end of the year for their taxes and stuff. You don't see that very much anymore because a lot of them have gone away from that. It wasn't beneficial or cost effective for them. The preferred provider organization contracts with a group of providers to deliver care. They have the freedom to choose any physician or hospital, but they receive a higher level of benefits if they see a preferred provider. So here they can see whoever they want. If they're on the preferred list, it might be a $10 copay. If they're not on the preferred list, but they're going to John Smith because they've seen John Smith for years, it might be a $30 copay. But they have that choice. And typically what happens with the preferred provider organizations is there's certain criteria that the providers or the practices need to meet in order for them to be considered preferred. Like we have been trying to be preferred with a certain insurance for a while, but we're not only, there's more than one orthopedic practice in our area, and because there is, we don't meet the percentage of patients that's required with that insurance carrier to be considered preferred. We see lots of patients, we just don't have the numbers with that carrier. So patients are going to pay more if they come to us. Silent preferred provider organizations, they may be referred to as silent. They gain ability to limit reimbursement. They're unable to get paid out of network, which reduces their income. Again, these silent ones are not something that's in our area. Physician provider groups, PPG, physician-owned, that has flexibility to deal with all forms of contract medicine and still offer packages to business groups, unions, and general public. Point of service plans, elements of the HMO and the PPO while offering some different unique features. So in a POS program, the members have a PCP that manage their care, but the point of service plan allows them to choose services from a participating or non-participating with different benefits. So again, they may pay a higher level of benefits when they use the POS side of it and pay less when they use the HMO side of it. So again, it's that flexibility, and most of the employers will find that by offering these point of service plans, it's actually cheaper for the employer and it gives more flexibility for their employees. Triple option allows members to select from 3 choices: HMO, PPO, or traditional. Provider sponsored, a managed care owned and operated by a hospital or provider group, not an insurance company. The Religious Fraternal Benefit Society, that is a managed care dealing with church groups or a group of churches. I've never seen that particular type of coverage up here, so we may not have big enough church organizations. Employee Retirement Income Security Act. Be aware that no matter what type of plan coverage, it's either purchased by an individual or paid by an employer. Because when an employer pays for the plan, it's regulated by the federal or by Employee Retirement Income Security. So again, small businesses, self-employed, uninsured, they can pick plans through state-based purchasing pools. Large employers, more than 50 employees, must pay $2,000 per employee fee, excluding the first 30 employees from the assessment. So because it's regulated by the Security Act, there's certain requirements that the employers have to meet. If you look on 376, up at the top, it just gives you like the HMO, the PPO, the IPA, the different types, and then if you're in network versus out of network, what the different percentage and coverage would be, whether it's a fixed copay versus a deductible or capitated or fee for service. No employer is obligated to do the employee benefit program, but again, it does fall under federal jurisdiction, so most of them probably will do it. Quality improvement organizations, these were formerly known as professional or peer review. They contract with Centers for Medicare and Medicaid. They review medical necessity, reasonableness, appropriateness, adequacy of inpatient care. So they're looking to make sure that if the patient, for example, is an inpatient, that they truly need to be an inpatient. If somebody is billing a follow-up visit at the hospital every day, but they're saying the patient is stable and improving, this type of organization might question why the patient is still an inpatient, because they're trying to save money. If the patient's doing good and improving, and they've been doing good and improving for the last 7 days, why are they still there? Quality improvement system for managed care. It's an initiative to strengthen the MCOs to protect and improve health and satisfaction of Medicare and Medicaid. So again, they're monitoring quality improvement, making sure data collection, analysis, reporting, stressing the importance and making sure that it is done. Utilization review of management, UR. Necessary to control cost in managed care. The UR committee reviews cases to determine medical necessity for certain tests and procedures, and it watches over how providers use medical care resources. If, for example, a test or procedure are denied, patient needs to be informed why it was denied, what the risk is, written reasons for denial, letting them know their rights to receive the service and obligation to pay anyways. A lot of times this utilization review, when they're determining whether or not a procedure should be paid for, it's not even a provider on the other end determining the medical necessity. So sometimes the provider will need to speak to a provider at the insurance company if a procedure is denied to say, look, this patient has a complete rotator cuff tear, and you're saying you're denying a repair of that? Why? Well, maybe they didn't get the documentation about the MRI. Well, we did an MRI. Here's the results. And it's maybe something that simple. But emphasis is placed on seeing high volume of patients in a performance-based reimbursement. Management of plans, contract, straightforward. You have a contract between your medical practice and the insurance carrier. Have the contract reviewed by an attorney before signing with a managed care plan. You want to make sure they've put no loopholes in there for you. When a MCO contracts with a physician group, how many patients will that group provide? what is the per capita or the capitation amount, and what services are included in that capitated amount. Services not included in the contract benefits are called carve-out. So that could be, if you look down below, it talks about EKGs, spirometries, hematocrits, fasting blood sugars, urinalysis. Those may be included in the capitation amount per person per month, regardless of whether any of these services were rendered. So that's why I said they started pulling away from doing these capitation contracts, because the insurance companies realized that they were paying out money and patients weren't having the services because they didn't need to be seen. So by switching to only paying for services that are done, it ends up saving the insurance carriers. Plan administration, inform managed care subscribers in writing what is expected from them and what they can expect in return. Patient information letter should outline restrictions, non-covered items, expectation for copays. Note if the patient neglects to notify office of any change in eligibility status, such as disenrollment, patient is personally liable for the bill. They should be notified of whether or not or how they need to go about getting referrals, that type of thing. It's getting a little bit better, but there's still a lot of work out there to do by the insurance companies about making sure that patients are aware of what their policies cover and what they don't. Because a lot of patients, they don't even know what an out-of-pocket maximum is. They have no idea. They just know they went with a low deductible because they were going to be covered 10% after that. Well, that's good, but you still got an out-of-pocket maximum. So that 10%, you're going to be paying up till $20,000. You know? So there's kind of a balance there. This state, because of the restrictions, failure to do so if they don't notify you of changes will make the patient liable for denied services, and this can be done in a waiver of liability, and in the Medicare program it's called an advance beneficiary notice of non-coverage, or an ABN. Some waiting rooms will post that information as well. Medical records, when you have an EMR, patient's account can be identified with a patient type corresponding with their type of insurance. So you may be able to electronically mark all your Medicare patients or all your Anthem patients. Scheduling appointments, screen patients to determine whether they belong to a prepaid health insurance or what type of insurance they actually have. And again, taking a copy of that insurance card to check the primary care. One nice thing about our system is when we check eligibility, it will come back and tell us who the insurance company shows as that patient's primary care. A lot of times, who the insurance company shows is not the same thing as who the patient says they're seeing. So that is something that needs to be addressed, because if you're using an incorrect primary care, that is going to cause your claims to be denied because you're not going to be able to get appropriate referrals. The encounter form, a lot of managed care plans use internal document for the services that are rendered. So like that one we saw earlier tonight about the checkoff. So the codes are on the top, the diagnosis. This is used as, or can be used as, their billing statement. Of course, now we submit claims on a 1500, so the actual encounter form is not sent to the insurance company, but that information is relayed on a CMS 1500 form. When we talk about prior authorization or prior approval, some of the managed healthcare will require pre-auth or prior approval in order to see a specialist. So a formal referral an authorization request required from the managed care contract to determine medical necessity. This can be done via phone or that particular insurance's authorization form. Direct referral, authorization request completed and signed by the physician and handed to the patient. Certain services may not require completion of a form, and they may be directly referred for, like OB care, for example. A verbal referral, PCP informs the patient, telephones the referring physician to inform the patient is being referred for an appointment. And then a self-referral, which means the patient is sending themselves. Maybe the PCP didn't want them to go, but they decided to go. Patients may be unaware of these prior approval requirements, and that is a big issue because they may not realize that they have to go through their primary care. They don't know what the HMO plan is. They just took it because they don't pay that much a month for it. They don't know the difference between the PPOs or the POSs. So when you are dealing with referrals or prior authorizations, have a tracking system, such as a referral tracking log, so you can track those pending referrals so that if your patient's due in next week and you called them today, have a way to follow up before they come in for the appointment to make sure you have that authorization. They say typically a 2-week turnaround time. Most of them can be done online now, so it may not take that long, but at least give it a week. If managed care refuses to authorize payment for recommended treatment, have the PCP send a letter to the plan that may enable it to be paid for. I say rule of thumb is any service that you're providing for your patients, if you're going to do that procedure in your office, you should call and make sure it's covered for your provider ahead of time, or if it needs a authorization. In some managed care plans, when a PCP sends a patient for consult to a specialist who's not in the plan, the specialist, instead of billing the patient or the insurance, they bill the PCP. So, never heard of that, but it can happen. If a specialist recommends referral to another specialist, that's called tertiary care. We want to make sure that the recommendation is provided in writing, because that referral or authorization might have to go back to the primary care, to the other specialist, instead of specialist to specialist. When a referral or auth is received, make a copy for each approved office visit or testing if that happens to be the case. Use the form as a reference for billing, and we actually have a way to enter those referrals right in our practice management system. So the authorization numbers are entered, and then when I bill, I'm able to attach that authorization to the appropriate visit, and then the insurance company can see that yes, indeed, we did have it approved. Diagnostic tests, again, managed care require patients have labs or x-rays. These are referred at certain facilities. These are referred to as network facilities. So again, they will be covered to the patient at a lower cost than if they go outside. You can see on page 380, this is an example of an authorization request form. So you're filling out the diagnosis codes, what you are requesting be done, giving a procedure code, having the physician sign it, providing this is allowing the primary care to sign off on it, and it gives the insurance company name. A lot of them, like I said, can be done right online with each individual insurance carrier, and each individual insurance carrier may have their own forms, so you may not even need to do up your own form. There's an example on 381 of a authorization log. So again, having a way to keep track of those referrals that you are calling the PCPs for or somebody for. I tend to just print out the schedules, and then I go through my schedules and I highlight the insurances that need referrals, and I do all my work right there on the schedules, and then I just keep those. A letter to a managed care plan when there's refusal to authorize payment. So this physician is stating why he feels it needs to be paid. They're sending copies of the labs, and they want reconsideration. So they're trying to now get that reversed. And then on 382 is that letter sent to the patient saying that the insurance company is refusing to pay. Now, if this is the case and the insurance refuses to pay, again, you can have the patient sign a waiver, and if they sign a waiver, then it will enable us to bill the patient. Now, in Medicare's situation, if we have the patient sign an advance beneficiary notice, when we submit the claim, we have to let Medicare know that we had the patient sign that ABN by using a modifier GA on the claim. If we do not put that GA on the claim, what happens is Medicare sees that CPT, it pops out saying it's not covered, and on the explanation of benefits, it says amount covered 0, provider responsibility, and there's the amount. By putting the modifier GA, because we've let the patient know it's non-covered, and they've opted to have it done anyways, when they see that modifier GA, that now, let's say $300, is now not in the provider responsibility, but it's in the patient responsibility column, because Medicare knows we had them sign a waiver. That's the only way you can bill your patient. If it's in the provider responsibility column, you cannot bill your patient. Now, your patient may not realize it, and you could bill them and they'd pay it, but if somebody checked records and you didn't have that ABN and you billed a patient for something that you should have written off, that's fraud. So the GA modifier. And you can, I don't know if it shows it in the Medicare chapter. You'll see it after the break when we go in. It's actually on page 410. There's a copy of an advanced beneficiary notice, and if you just go on to CMS's website and under search put ABN, you can pull it and print it as well. But it allows you to put what it's for. Medicare does not usually pay for this, the estimated cost, and then the patient has the option to say, I want it done, I will be responsible for it, I want it, do not bill Medicare, I'm just going to pay for it, and they can't appeal to Medicare, or I don't want it, and period, they're not going to pay for it. So they have the option. So with the managed care, insurance companies, they're just saying some practices keep information in a 3-ring binder with dividers for each insurance plan, and it works out really well if you're able to, even their newsletters, if you have a Blue Cross section, keep in there, their ABN forms or their authorization forms, anything pertinent to that plan that is going to help you guys process claims, anything you need to know. And then most recent can always go in the front, or you can set it up to have dividers within the specific carriers. Payment, again, deductible. Usually there's no deductible for a managed care plan, but again, if there is one, if the patient's met their deductible, great, then they're just paying a percentage. So you can bill the insurance and then bill the patient once we get it. Some offices, if January 1st rolls around and they know the patient has a $5,000 deductible and they're doing a colonoscopy on them January 4th, that office might make the patient pay up front because they know their deductible's not been met. If If that's a policy of their office, that's okay. Some offices don't like to collect deductibles up front, just because if you say you're going to do it, you got to do it for everybody, and you got to do it all year. So you're forever checking those deductibles. And some people don't meet their deductibles throughout the year. Others, they've met it, and then if you've collected, now you've got to generate a refund, which in turn costs, because now you've got to cut a check, mail it, whatever it happens to be. Again, copays, they're predetermined amount, so those can be collected at the time of the patient's office visit. It is not cost effective to have to generate a statement for a copay. The last I heard, on average, it costs between $10 and $12 to generate one statement. So therefore, if your copay is $10 and you have to send 3 statements, you've lost money on that copay. And I think the last time I saw that updated, it was it was last year, 2016. So they figure that $10 to $15-ish is the time it takes for you to, prepare that statement for the patient, send it to the patient, the paper, the stamp, whatever it happens to be. If you look on 383, again here you will see this is a reference for insurance companies. So you could also list your insurance carriers, the contact number. Obviously the copays aren't going to be that easy because they're strictly plan driven. All Aetna plans do not just have a $5 copay. But it does, you could put what's required for authorization for the services that you perform. If there is test restrictions, who they might use, like if you're ordering an MRI, you might need to go through NIE in order to get an MRI authorized. If that's a standard for Aetna, you could put that information, and then it's a quick go to Aetna, see who we have to call for x-rays or whatever it happens to be. Okay, so what I am going to do is I'm going to leave off right there on the payment models. We've only got payment models and the statement of remits really much. Yeah, we've got like 3-4 pages left. So you can go ahead and look through those. It is pretty straightforward, but I will, when we come back, just briefly touch over the last 3 pages here, and then we will go into the Medicare chapter for patients. And as you'll see, these last few chapters that we're going to cover have to do with the different types of insurances. The Medicare, the main care, TRICARE, workers' comp. We'll talk about the disability coverage, and then we talk briefly about hospital billing, and then seeking a job. So we'll go over a little bit of the carriers, and if I think I know you're already working, but if you at the last chapter about seeking the job, Amy will, if you submit a resume to her, she will just look at the resume in case you in the future want to apply for something else. She'll let you know where you can add certain things or how to make your resume look better. So even though you have a job, I do recommend that, because she can, really dress them up without giving false information, obviously. And it may not be something that you think you would add on there, but it might be something that will make you more marketable.
Yeah.
So.
And I always submit it anyway, just because you always should have one handy, because you never know.
Right, exactly.
Always have a current and good looking resume, because you never know. You could be in a situation where, hey, do you have a resume?
Right.
Yeah, why? Oh, well, just, you never know. It could lead to something else.
Yep, exactly. All right.
When we talk about Medicare, we are going to talk about billing with regard to, because I know that there are a few instances where Medicare is secondary.
Yeah.
There's not very many, but we are going to talk about the little things that have to do with that, correct?
Yeah, we talk about the situations when Medicare is secondary. It doesn't, typically, if Medicare is secondary, you bill your primary. Your Medicare has to be secondary for certain reasons. So there's only, and if you look at, if you're able to pull Medicare eligibility electronically and Medicare is secondary, it will actually tell you why Medicare is secondary. So like the person has end-stage renal disease, or the eligibility, the spouse or whatever has regular health insurance, so that's why the Medicare is secondary. It will give you what those reasons are. But typically, after you send to the primary insurance, when you get that back with their explanation of benefits, all you do is you take that primary insurance's explanation of benefits and send it to Medicare. The only thing you need to do is, let's say you're billing Blue Cross primary, and for that screening colonoscopy, Blue Cross doesn't have a special code for that. It's just 45378 is the CPT code for a colonoscopy. That's what you bill to Blue Cross. But Medicare has a G code for screening colonoscopy. So before you submit that secondary claim to Medicare, you've got to make sure that you've got the correct Medicare code on it. You don't change your fee, but you've got to make sure that the Medicare code is on there. Or like in our physical therapy claims, Anthem doesn't require modifiers on their PTs. But if we bill Medicare as a secondary, Medicare needs modifiers. So we have to add those modifiers before we can submit it. So yeah, we'll touch on the secondary and how to bill them.
Okay, so you're essentially, if Medicare is second, you would be changing, well, you'd be altering the claim before it went out to the secondary.
If Medicare's got different codes than what's accepted. Yep.
Okay. Now, if it's reversed, if Medicare is primary and say Anthem secondary, because you have the same issue, exact same, procedures, would you be switching it to the Medicare? Would you be altering the Medicare one going out secondary?
It depends if Medicare crosses it over electronically for you. If Medicare crosses it over electronically to the supplemental plan, and the supplemental plan doesn't require that the code be changed, then they're just going to process it anyways. But if the secondary gets kicked back because they don't allow Medicare's code, then yes, you have to change it to the code that they would allow.
Okay.
Yeah.
Yeah. A lot of this for me is I'm still trying to figure out how the system, how the management system processes it.
Yeah.
Because I'm trying, like, a lot of stuff that I'm seeing in my book as I'm doing some of the grunt work, I guess, for the billing. Like, so I'll get notes from the billing department saying, oh, I've this insurance doesn't match, contact the patient, see if they have a new insurance card, or I've these claims have been denied a couple times, like that the email that I had sent you with that one patient. And I went on to CMS, and they have that tool that you can put in what the rejection code is and see if something comes up. So I did that first, so I wouldn't spend a long time on the telephone with Medicare. I put in A8, I put in 163, I put in GB, I hit search, no entries found. I'm like, what? So I had to call Medicare.
It went to the other insurance, right?
Medicare. Well, when I talked to Medicare, Medicare said, oh, we don't have any claims for that patient at all for those dates of service. And I said, well, how can you deny it if you don't have the claim?
Right.
And they said, well, maybe the system, he said, do you know if the billing department is using a clearinghouse? Because maybe it's the clearinghouse that's kicking it back, not Medicare. And I said, That's a very good question. I guess I'm going to have to ask the billing department that, because that was not in the information that I had. It turns out that it's supposed to be our system sending it out, and there's got to be something going on with our management software. And I guess this has been going on with like many different things. So I ended up today having to send a paper claim.
Oh, wow.
To Medicare for those two things, just because it's end of year. And I had an envelope ready because I was sending another claim to Medicare for something else to the same address. Like, well, if you haven't gone to the post office yet, just print out those claims and put it in that one. I'm like, okay.
Wow.
So I'm still trying to figure out the system so that I can,
right,
see where the glitch is, because if it's something that I have to sit, because part of front work, that's how I'm learning everything, is to start doing like the lowest stuff. So it will be me being on the phone with tech support saying, okay, explain to me how we can fix our system, because we're paying X amount of dollars to use your system, and it is not doing what it's supposed to do.
Right, because you could end up getting more.
Find another company.
Right, because you could end up getting more of those claims denied for the same reason. And that's not going to be cost effective at all.
And it made no sense at all, because it just kept saying, it kept saying that it was the patient's policy number. And I'm looking at it, and I know the policy number's correct.
Yeah.
I'm looking at the insurance card, and I know it's an accurate one because the patient had just come in. And while they were there, I said, oh, hey, could I take a look at your insurance card? I said, I know it's not, our normal time to look at it, but if you have it, could I take a look at it? And they're like, oh, is there a problem? Because people get really nervous.
Yeah.
I'm like, no, not. I said, no, I just have to make sure that what's on your card is what I have in my system. And it matched. And I took a second copy just to make sure.
Wow.
So it's like computer is helpful but not helpful,
right?
Kind of situation.
Yep, I hear ya. All right. Well, if anything comes up over, yes, you too. If anything comes up, I'll get back to you on those ones. But anything else come up, just shoot me an email.
Awesome. Thank you. Yeah,
All right,
I kind of was hesitating on taking the Chapter 10 test until I got my answers on Chapter 9, so I didn't confuse myself.